Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent sponsorship from Amgen, Inc.
This program is presented by Medscape Education Global.
Hello, my name is Kaushik Ray. I'm Professor of Public Health and Consultant Cardiologist at Imperial College London. Welcome to this activity entitled Staying Ahead of the First Event, Evaluating the Evidence for Early LDL Cholesterol Lowering. Now, joining me today are two good friends and colleagues, Professor Lale Tokuzoglu, Professor of Cardiology from Hacettepe University in Ankara, Turkey. Lale, welcome.
Thank you.
And also joining me, and probably it's somebody that you're going to really enjoy her discussion and presentation, is Dr. Erin Bahula, who's Assistant Professor at Harvard Medical School, and she hails from Boston, Brigham and Women's Hospital. Welcome, Erin.
Thanks so much for having me.
And so I want to basically just set the scene a little bit for this whole session. And one of the things we sometimes forget when we think about cardiovascular disease, we tend to kind of dichotomize, people that have had chest pain, heart attack, bypass operations. But let's take a step back. So we've got a global population of 8 billion individuals, and there's huge complexities, right? So we have a number of things that we basically need to think about: the health system, the patient, and the physician. And we constantly try to bring this triangle, if you will, together, and we're interconnected. And a little change here and there, whether it's knowledge, whether it's, patient beliefs, changes a lot. That access to medications changes a lot of that. But we've got a disease here that we constantly talk about, the number one killer in the world. And we know what the modifiable risk factors are. And in fact, there are studies that have shown that effectively most of those cardiovascular fatal and non-fatal events that will occur are preventable because there are things that we already know, and they account for about 60% of those events. And one of the challenges that we have about risk assessment and decide to do something is what we do before somebody's had an event. And unless we start thinking about risk factors as a continuum and not binary, we basically will miss opportunities. So most of those events that will occur in people with, which a lot of people call normal. And that's a problem because the average age is 54. The blood pressure is systolic, is not particularly elevated. The average non-HDL is not particularly elevated. So we've got to basically separate that. And I think one of the things that I really started to think about is that interplay between what makes an individual vulnerable, which is our genetics, good days and bad days of risk factors, and how we then present, and so your genes don't have to be your destiny, but thinking about your long-term risk does. And if you can start and modify your risk factors, and if you can do it with thoughts and prayers, fantastic. But most of us will probably need a little bit of a helping hand with medication. And when we do that, we can probably make change. And, there's some lovely work done by Nick Nur Mohammed, and he's done a lot of interesting studies in showing basically that many of those individuals that will present for the first time had no warning the day, the month before, didn't seek a healthcare professional. And so where is the opportunity for those individuals? And when I think about this a little bit more, you think about people's life courses and you think about starting to prevent or change behaviors, primordial prevention to develop atherosclerosis, and another group of individuals who are early adult life, and many of those we know will have atherosclerosis. We want to slow down because we know that that will predict events. And there's a whole group of people who actually feel fine in themselves, no symptoms, but then by chance maybe you've done some imaging, you've looked at their blood vessels, and you find they have way more disease. And now they're a little bit older. So as good as we are, we don't yet have a time machine that's going to take people back. So we've got to think about what we need to do in terms of those individuals. And And I think this is where recognizing that cholesterol lowering has a role to play, but also then combination therapy, because the vast majority of people will need more than one drug if you are starting later on or they're at higher risk. And, we showed that with Da Vinci. And all you do is change the goalposts and fewer people get to goal. We're getting better. We've moved from 10% combination therapy to about 37%. Goal attainment's improved from 20 to 30% as a result of that. But it is not yet enough, right? And so one of the things that we need to perhaps think about is thinking about moving away from symptom-driven angiographic stenosis to atherosclerosis, and thinking about the disease and talking to our patients in that way. And I know you both made significant contributions, both in terms of diagnosis, imaging, understanding of that, and treating that. So I'm really looking forward to what you will have to say about that. But do you think the time has come for us to actually change the narrative, to both of you? What do you think? Lally?
Yes, definitely. We need to understand who has significant plaque, who has obstructive plaque, and move away from the dichotomy, as you said, of primary and secondary prevention to the paradigm shift of who has significant risk and who is going to have an event. We only treat the tip of the iceberg in our clinical practice, but in the bottom, there's a huge amount of individuals with subclinical atherosclerosis or risk factors waiting to have subclinical atherosclerosis.
And again, really to reiterate that, you mentioned plaque. Just reiterate really why you think the link between plaque and events. I mean, because a lot of people will think about hyper this and hyper that, and we've got to change. So perhaps, why is plaque so important?
Well, the imaging studies have taught us that if there is significant plaque or if there is vulnerable plaque, the likelihood of having an event is very high. So,
And these are people who are asymptomatic. That's the key,
exactly,
right?
that's the key, yes.
And
Yeah, well, I mean, I agree with what both of you have said, right? I mean, the disease is a spectrum. It is not binary, and patients can have subclinical disease, and we know that their lifetime risk is still significant of having events later on. And so it's important to identify those individuals who are at risk, and imaging is one way to do that, and do that very effectively to identify patients who are at future risk. And so, it's been built into the guidelines for that reason, as a way of sort of thinking about, we're all attuned to that patient who's had a prior event, right? But I think we need to be more attuned to people who have imaging evidence of atherosclerosis to think about them as somebody with a really significant lifetime risk of future events.
so I'm going to hand over to you, Lally, and because you've got some thoughts on this in terms of how we integrate all of this into risk assessment. So I'm going to hand over to you.
Yes, I think it's very important to assess risk because then we can actually select high risk patients who deserve immediate attention and intervention. And we can modify the intensity of our risk reduction efforts based on the risk estimate. This will also be cost effective. We're trying to get the right patient at the right time for the right treatment. And one other thing is that if we predict risk or do some imaging, we can actually motivate our patients to adhere to therapies because they'll think they're extremely healthy with no symptoms. Of course, in the guidelines, we have the risk prediction systems. And in the US, they use pooled cohort equation in the 2018 multi-society guidelines. In Europe, we use the SCORE2. SCORE2 is the new risk stratification system in Europe we use for those below the age of 70 and OP for over the age of 70. The good thing is that it has been updated with contemporary data and gives us the 10-year risk of not only cardiovascular or fatal, but both fatal and non-fatal events. And it can be recalibrated according to the 4 European regions. For those with high risk and above, we will need at least a 50% reduction from baseline, and with goals of less than 70 milligrams per deciliter for high risk and less than 55 for very high risk. This means that a lot of these high risk patients are going to require combination therapy. It's not easy to get to goal with monotherapy, and it is possible with the armamentarium of lipid-lowering therapies we have today. It is possible to get to those goals But with higher risk patients, it's usually combination therapy that is required to get those more stringent goals. The US guidelines are taking a slightly different approach, and if you're at high risk, they recommend a statin, including those with FH and diabetes. And for borderline and intermediate risk, you can use risk enhancers. If you have 3 risk enhancers or a non-zero calcium score, then you can also initiate statin right away. And what both guidelines agree on is that you need at least a 50% reduction from baseline for those who are calculated to have high risk. So, taking these into consideration, and of course, risk enhancers are very helpful. You can look at family history, LPLA, inflammation, female associated risk factors, and try to individualize everything better. But instead of trying to look at all these risk factors and trying to come up with a risk, why don't we just look at the artery itself? So that will be direct detection of atherosclerosis, and it will give us a memory of lifetime exposure to all the risk factors. And of course, there are a lot of imaging techniques, but those that we really should focus on are CT. We can look at calcium score or plaque at CT, or looking at ultrasound imaging of the arteries where you detect the plaque itself. And one that is more frequently used is calcium scoring. It only quantifies the amount of calcified plaque in the coronary arteries, and it may seem limited, but the more plaque you have, the more likely to have calcified plaque. And having a calcium score of non-zero has been shown to reflect low short-term risk. And if it's over 100, that shows that we do have a moderate plaque burden. And over 300, this is most likely obstructive atherosclerosis. And the new European guidelines are highlighting the fact that these patients will be automatically at high risk or above. The US guidelines has incorporated calcium scoring much earlier than we did, but now we have recently updated the European guideline, and now we recognize calcium score as an important risk modifier as well. And looking into the future, yes, calcium score is very good, but it doesn't really show us the vulnerable plaque and non-calcified plaque. So now there are new AI technologies looking at CT that can quantify the plaque burden, and some others can actually show us the vulnerability of the plaque. So maybe, hopefully in the future, it will be a one-stop shop to see how much plaque we have accumulated and how dangerous it is.
And what you're basically showing, I think, very, very nicely is that you are showing how, with looking at genes, environment, and time with imaging, that actually you are bringing together that personalized medicine. And what you basically are showing is that that you may be able to take the totality of evidence together and maneuver things in a way that actually is helpful. So Lai's given a really lovely overview of our previous approaches. So the more data points you have, the better. And the point that Lally was making about SCORE, the reason that was important is that we went from looking at only fatal events, where he got to be predicted to die, quite frankly. And it was disenfranchising younger people and females as a result of that. So moving to fatal and non-fatal events made a big difference in terms of precision, and then recalibration, taking into account diet and lifestyle. Still imperfect, imaging, and you've thought about this, so maybe give us sort of a brief background to how that can help us, and then what you and your colleagues have done at TIMI with a fantastic new trial and what it adds.
Yeah, no, I'm happy to. If we take it all the way, back to the statin trials, we know that LDL is a modifiable risk factor, and if we can effectively drop LDL, we can improve the fatal and non-fatal events with statins, and that's across the range of risk, right? That's primary prevention, that's secondary prevention. And so then the next step has been to say, well, as you've highlighted, most people are going to need combination therapy. High intensity statins may not get us to the area, the level of LDL that we want to be at. And so what other agents can we use to really drive down that modifiable risk factor, the LDL cholesterol? And so it started, with the additional agents, the PCSK9 inhibitors, with trials where they looked at individuals who were at very high risk, right? Patients who had had prior events and MI, stroke, symptomatic PAD. And, there were two important sort of seminal studies with the PCSK9 inhibitors, evolocumab and alurocumab, and that was the Fourier and Odyssey outcomes studies, where we saw, profound reductions in LDL, 50, 60%. And improvements in cardiovascular outcomes. But what we sort of realized is, when you look at the guidelines, I think very appropriately so, it says really drive the LDL down in these patients, and we've moved to saying, including patients who have, for example, imaging findings of atherosclerosis, not just prior events, into the very high risk category. And so we want to push down their LDL quite aggressively. And as you mentioned, we have goals now of less than 55 milligrams per deciliter, for example, in the European guidelines, and even more recently to consider less than 40 milligrams per deciliter in those extremely high risk patients. But I think one of the things that we recognized that we were missing was, um, do we have proof with these non-statin therapies that we can improve outcomes, in these lower risk populations by pushing the LDL down very low? And so that's where we then designed the Vesalius trial. And in designing it, we thought about ASCVD as a continuum of risk. And so this is just another way of sort of conceptualizing what we've been talking about, which is to say that, we have patients who we don't believe have any ASCVD, and they're low risk in the face of minimal risk factors. We have patients who have no known ASCVD, but we think of them as being higher risk for development of future disease because of risk factors like diabetes. Patients who have atherosclerosis, but who've not had an atherothrombotic event, and then patients who've had prior atherothrombotic event. And as I highlighted, the prior studies with the PCSK9 inhibitors really focused on those very high-risk individuals. And with the Vesalius study, which I'll describe in more detail, we decided to take a step back and to look at a lower risk population, those patients who have evidence of athero, for example, by imaging, who haven't had a prior MI or stroke, as well as patients who don't have any known athero. Maybe they have subclinical athero, but it's not been identified, and they have risk factors in the face of diabetes and others. And so when we designed the Vesalius study, we included a couple different populations. Patients had to have at least one of the following four: coronary disease without a prior MI, cerebrovascular disease without a prior stroke, peripheral arterial disease or high risk diabetes, and they also had to have elevated lipids, LDL cholesterol of at least 90 milligrams per deciliter, or some other parameter being elevated. And then they were randomized to treatment with evolocumab or placebo for a median duration of follow-up of 4.5 years, which was an important distinction with this trial. And then we followed them for dual primary endpoints, which were sort of composites of a coronary heart disease death, MI, and ischemic stroke. And then the second composite was those same elements plus ischemia-driven revascularization. And ultimately, the patients who were included in this study were about 12,000 patients, a little bit over, who had a mix of disease states. So about 2/3 of them had one of these qualifying atherosclerotic disease states. Half had high-risk diabetes, and a third of the entire trial had high-risk diabetes alone without qualifying atherosclerosis. The patients were treated quite aggressively with lipid-lowering therapy, so 72% were on a high-intensity regimen, so one that would be expected to drop LDL by about 50%, and 68% were on a high-intensity statin. The median LDL was 122 milligrams per deciliter, so pretty generous in this population. And with treatment with evolocumab, we were able to drop that down to 45 milligrams per deciliter. So it was about a 55% reduction, consistent with what we've seen with this therapy in the past. Or in absolute terms, it was about 63 milligrams per deciliter. And with that, we saw a highly significant improvement in outcome. So a 25% relative risk reduction in that 3-point MACE composite and a 19% relative risk reduction in the 4-point MACE composite. So quite compelling evidence of cardiovascular benefit for lowering LDL with this therapy in this population. We had a number of key secondary endpoints, and a few to note was there was a 27% reduction in the composite, the sort of more traditional MACE composite of cardiovascular death, MI or ischemic stroke, and a 36% reduction in MI. The first of the tested and death endpoints, coronary heart disease death, was not significant, but we did observe nominally lower rates of cardiovascular death and all-cause death, and specifically the hazard ratio for all-cause death was 0.80. So exploratory, but important. And I'll also highlight that in addition to our study, there are other studies that are ongoing that will be looking at the same thing. So one of them is Victorian-1 Prevent, which is a study of inclisiran in a similar population that even includes some lower risk patients than we studied in Vesalius. And as well as coral reef outcomes with enlicitide, which is an oral PCSK9 inhibitor, which we've just seen reduces LDL by on the order of 50 to 60%. And similar to Victorian-1P, that has a patient population that is like Vesalius. There's also some patients who are a little bit lower risk, and then also patients who are similar to the prior studies of Fourier and Odyssey outcomes. So I think we were very excited to see the results here, and then I think it really lends support to the European guidelines and what has been said for a while, that we really we need to think about treating these patients aggressively at earlier stages in their disease.
So it really is I think when the dust settles and people really understand the relevance of this, and I think what it shows is that if you think about the global population as a pyramid, there are fewer people who've had a heart attack, a stroke, and a bypass and survived all of those bits. So the established, and there's a bigger group below coming up to that point, and it's a much bigger group, and they are, I think, being underserved because one, we're not assessing risk properly, which is what you talked about, and then two, what you've shown very nicely is that we have treatments that we can then offer them now. So we have to think about, essentially, it doesn't mean everybody has to have imaging, but you have to think risk. If you don't think risk, and leaving people with an LDL of 122 versus 45, you've seen the difference that it makes. And the other, I think, key thing that I really, really liked is the importance of time, because that was a criticism of the previous PCSK9 inhibitor trials, which were that you've got this big percentage reduction in LDL. Why didn't you make more of a difference? Well, we didn't treat for long enough because the disease didn't happen overnight. It took 50, 60 years. But now, if you allow nature enough time and you change what the body is kind of being marinated in, if you will, your LDL exposure, magic starts to happen. But you need that combination in time. So, Lally, what did you think of the data and where this fits into clinical practice, and how do we think about implementing it?
I think the data is very impressive and shows that treating aggressively earlier on is going to make a major change. So we should shift our focus from patients who already have an event to those who have not had an event yet and try to prevent it. So I think it just goes well with the ASCVD risk continuum, trying to catch patients at an earlier page where the plaque may be even more modifiable, because after an ACS, it's all calcified, very advanced plaque, and catching the plaque earlier on will make a difference.
And I think that those are extremely important points. And Erin, we talk a lot about pleiotropic effects of statins, this, that, and it really, the commonality of everything is the LDL change. That's what's driving it. And showing that actually it's not the percentage change, it's the absolute difference and time that makes it, that really makes that magic happen. How important do you think that is? Really, it's not necessarily just PCSK9 inhibition, it's LDL, isn't it?
Yeah, no, I think this reinforces what we've all been saying for a while, that it's really about the LDL. But this is just another piece of evidence to support that. But I think what you said is super critical. The notion the amount of LDL lowering, the absolute amount of LDL lowering is really what is the driver of the magnitude of benefit. And I do think also it's been very well described, and this reinforces it too, that it takes time to see that benefit, right? That upfront in the first year you don't see very much, and it grows over time. And so you really need to allow, as you said, nature to
Yep.
take its course with these therapies. And it's not about PCSK9 inhibition, I don't think. I think it's about LDL lowering and time. And I'll also highlight too that the mortality observations, I think are also, a part of that story as well.
Yeah.
That those curves, and actually from the statin trials too, they take a while to diverge, right? It takes year 1 to 2 years of treatment, and so I think if you want to observe those
You got to go
benefits,
longer.
yeah, you got to go longer.
So with all of this, I mean, one of the things that we walk away from these meetings very enthused, and I started off with those three things: the patient, the healthcare system, the physician, and the patient. And clearly, things have to be available. So have to be obviously affordable, accessible, not complicated to access. So that's one of the things. So for each of you, I'm Laia, maybe I'll ask you about the physician perspective. Think about the barriers and what we can actually now do with the data that we've got to actually improve their understanding and usage. And then maybe, Erin, I'll just finish with you and think about, from the patient perspective, how we can try and convey information in terms of risk and benefit. So Lally,
I think, first of all, risk assessment should be performed more appropriately. There's surveys across Europe showing that most physicians do not employ the risk stratification systems. They go by experience or by national recommendations. So I think, first of all, the physician should look more into risk stratification. The second thing is therapeutic inertia. There are several surveys also showing that when asked, the physician will say, yes, this patient definitely needs combination therapy, but in real life studies, like you have shown, it's really underutilized. It is getting there, but there needs to be more education. There's also knowledge gap between levels of care. When the patient is discharged, for example, with an ACS or the diagnosis of chronic coronary syndrome, this is not really being reflected in the general practice. So that is another thing which can be solved by education. And of course, there's the issue of polypharmacy, where the physician really does not like prescribing too many medications. The patient is going to resist it. And of course, there's lack of time, which is a problem, because for shared decision making, explaining the risk to the patient, you do need time. And in the current systems, that seems to be a luxury.
and that brings in Erin in terms of her thoughts, because the stuff that we're doing is, how do you explain risk, because it's asymptomatic,
Yeah.
and it's not like weight loss where the patient can immediately see something. You're doing other stuff as well. So what about the patient perspective? How do we translate some of this so that they're engaged?
Yeah, I think it's a challenge, right? I think, as you stated, I mean, I don't. Many of these patients don't feel bad, and they don't appreciate the risk of their elevated cholesterol. And so I think it's highlighting for them. One approach that I've seen used very effectively is to either show them what their risk calculator, what it suggests, and I think that's very helpful. I think another thing that is incredibly powerful is if you do happen to have imaging where they can see,
Seeing is believing.
100%, absolutely.
Seeing.
And you can show, sort of very simple figures where you say, here's studies where we've been able to sort of improve how these vessels look, not in the individual patient, but in studies. So here you've got disease, and we can make that better, and we can make your risk lower. And these are very well tolerated medications too. And I think the other thing that's really important as a healthcare system, I know we have many systems, is just the accessibility of these medications, right?
Yep.
And making sure that it's not very challenging for the provider or for the patient to get these medications, that it's not overly burdensome in terms of cost either.
Well, I think that's a really great place to actually finish. And the one of the things I think we probably need to think about is medicine, and health is for everyone, and not just for a few. So thank you both very much for a fantastic discussion. I hope our audience found it enjoyable and insightful. We've got a great set of tools, but to use those, we've actually got to assess risk. We've got to convey that. We've got to have the tools available, and let's see if we can make a difference over the next 5 years. So thank you both for joining me, and thank you very much to our colleagues for joining us today, and we hope you've enjoyed the presentation. And thank you for participating in this activity. Please continue on to answer the questions and follow and complete the evaluation.
This program was presented by Medscape Education Global.